I'd like to welcome all the co-instructors and speakers before I just start, and we'll be starting the talk now. So what this talk about is the new lingo that we all talk about in retinal imaging. That is, we call it the alphabet soup. So I'll be covering mainly the topics that is associated with dry AMD. And why it needs to be covered is that in the name also has a significant description by which we learn the pathogenetic process and mainly understand the evolution of disease, especially in AMD. So there's only two outcomes in AMD, that is atrophy and scarring. But there's actually only one outcome in AMD, that's atrophy, whether it is direct or secondary to scarring. And the pathway to atrophy can be in the absence or the presence of a CNV. The description of atrophy is two. One is a primary age-related atrophy, and the other is a secondary, not a secondary, a Drusen-related atrophy. And macular atrophy has been defined by the color fundus imaging, fundus autofluorescence, and multicolor imaging. And this is a seminal study that is combined the consensus group to define one of the simplest things we think, that is what atrophy, to define it. It is the report number 3, in which the OCT, fundus fluorescence, autofluorescence, and near infrared reflectance and multicolor have been used to define what we understand as atrophy. And the terms have been introduced, which are the CRORA, or the complete RP and autoretinal atrophy, IRORA, incomplete RP and autoretinal atrophy, CORA, and IORA. So to define the atrophy, the inclusive criteria of CRORA, complete, is that there should be at least an area of 250 microns of continuous hypertransmission. Hypertransmission occurs because of RP atrophy, and the signal goes down. There should be a zone of attenuation of RP atrophy seen tomographically, and also evidence of overlying photoreceptor degeneration. Any presence of a RIP or a scrolled RP is excluded to define CRORA. So this is some pictures from that seminal article, in which here you can see a continuous zone where the RP and the photoreceptors are lost, and hypertransmission due to that is seen. In an incomplete case, you can see that the areas of the RP is still persistent over there with photoreceptor retainers, and you don't see continuous hypertransmission or transmission of the signal in areas of intermittent normalcy. The interesting thing is that now the term we use of geographic atrophy is only considered a subset of CRORA, by which CRORA is also defined when there is a presence of a exudative membrane. So this is a typical example where you have a pigment epithelial detachment with content. Probably there's a possibility of fibrovascularity over there, but the area of transmission encompasses that, because the RP overlying this particular PED is also atrophic, and it still forms under the terminology of CRORA. So these are some of the examples we have. You can see the hypertransmission, a total loss of tissue overlying that area with the dipping of the vertical loss of stability and dipping of the layers. Here you have another significant larger area with areas where there is even a preservation of ELM in one area, but there's an area where the total photoreceptors have been degenerated. And another example where you can see a very clear cut and loss of the RP, and even in the presence of Drusenoid PEDs and PEDs, you can see that if the overlying RP is atrophic, you can have and define CRORA in the presence of that. How about the incomplete atrophy? The incomplete atrophy, as you see here, you see vertical hypertransmission defects, which show that in between areas there is persistence of the RP and the photoreceptor layer, which blocks the signal, and the signal continues downwards in the other areas. This is another example where you see incomplete defects, vertical transmission defects with normal areas intervening. This is interesting because, as I said, even in the presence of elevation, you can see vertical transmission defects, which show that focal areas of RP loss are present. This particular hyperreflectivity is called a core, which is another feature which has prognostic value in atrophy. The terminology called Nascent GA. Nascent GA is a subset of incomplete atrophy that happens in the absence of a CNV. That's very important to know. Here you see small areas, but what defines nascent GA is the dipping of the ONL layer and the INL layer. This is called, and hyporeflectivity here called wedge-shaped hyperreflectivity. This is what defines nascent GA or early phase of incomplete atrophy. So as I said, the subsidence or the dipping of the OPL and the INL layers you see here, and here you see hyperreflective areas which correspond to the dipping, and this forms nascent GA. Another terminology that we need to know is subretinal drusenoid deposits, SDD or pseudo-drusen. So any pseudo-drusen or subretinal deposit is anything that forms internal to the retinal pigment epithelium, in contrast to what we normally call drusen. So these are well-defined areas located above the RP. There's a 52% association in AMD, but this is like the presence of subretinal drusenoid deposits is like aggressive AMD or AMD on steroids, where there's a 3.4 times increase, or in some cases a 6.1 times increase of reaching advanced AMD characteristics like advanced atrophy or advanced exudation. So these are some of the examples of the triangular deposits that you see above the layer. You can see the deposits above the layer over there. And there's a predominance to be found in female and is highly bilateral. There is a theory for how SDD occurs. That is, there is a defect, two lesion, two compartment. There's a defect in the retinal pigment epithelium lipid recycling pathways that cause deposition above the RP. And also it has been thought that there is a derangement of the choroidal circulation. The choroidal capillary forms atrophy and fibrosis, therefore causing a derangement of the RP, causing all of this to happen. So they are dynamic structures. If you look in this picture, first there is only an obliteration of the layers, and subsequently mounds are formed, and then a triangular penetration of the ELM happens in stage 3. A few studies have noted that there is over a 3-year period, the choroidal thickness and the photoreceptors thickness decreases by more than 75%, and the area affected by RPD lesions increases at quite an alarming rate also. So these are some examples of things here. You can cleanly see the penetration of the ELM by the triangular deposits above the RPE. And over time, there is resorption, which leads to an atrophic change. And this is highly prominent and fast in nature. So there is an association of reticular pseudo-drusen with vascular insufficiency and choroidal insufficiency, females, and hypertension, which shows it could be not an atrophic lesion, but a vascular insufficiency lesion. So the other thing we'd like to talk about is hyperreflective foci, in which RP cells detach and they move anteriorly in the retina. So these, the RP cells instigate by producing deposits, they damage the brooks. The brooks in a reverse action causes more RP cells, and therefore these detach and move anteriorly. So here you can see the presence of hyperreflective foci on the presence of drusen over there. They can be seen above a drusenoid PED, as you see in this picture and in this picture. So over time, you can see these anterior, they call anterior migrating RP cells. However, there is also an alternative pathway for RP destruction. That is, instead of moving anteriorly, they move into the as a laminate deposit sideways, and this causes pseudo-vitelliform type of lesion with sloughing into the subretinal space, forms the anterior migration of HRF. So this is a patient with nearly a 10-year follow-up, and as you can see, this has a pseudo-vitelliform lesion. Over years, there are changes that happen, and over years you can see the atrophic changes increase. The pseudo-vitelliform material is resorbed, and finally it ends up in a severe and significant atrophic change. So we have two types of HRF: the anterior migrating, that is the atrophic pathology, and a posterior migrating, that it starts in the retina in vascular pathologies and they move towards the RP. We are here talking about anterior migrating RP cells or hyperreflective spots in atrophic AMD. An interesting thing we see is also called Drusen Ooze, which is characterized by two significant features. First, the presence of a hyperreflective foci or overlying the drusen, and second, isoreflective, which is equivalent to the drusen content coming through these defects in the RP above the drusen. And this phenomenon has been called Drusen Ooze. It's very nice to see some of the similar pictures initially showing hyperreflective dots on the top, with some isoreflective dots inside, and then a give way of the RP with the isoreflective material coming outside, like oozing out of the drusen. So here are some of the pictures you see where you can see a clear deficit or an aperture in the RP with material coming outside, Drusen Ooze. also a significant indicator of atrophic AMD. Here are some pictures in which you can see content coming out of the drusen. Wonderfully, here you can see a large gape in the drusen top with the material outside. A beautiful thing is outer retinal tubulations, which is a very commonly a degenerating photoreceptors trying to protect themselves, huddling together, and it is a common final pathway in many, many diseases. And it happens in the outer nuclear layer and happens when there is significant outer retinal architecture loss with a relative preservation of the photoreceptors which try to save themselves. So here you can see the presence of outer retinal tubulations or circular arrays of photoreceptors overlying a scar. And here you can see isolated ones with thickened borders, again over a scar. And this is an on-fast view, and it has a scrolled up appearance as you see over there. Okay. So ORTs based on cross-section can be closed, open, and forming or branching. The closed ORTs are stable, and they usually are take about 12 to 14 months, and they are called stable if they are present for at least 3 years. So the ORTs are an attempt for the photoreceptors in the failure of an RP to protect themselves where the RP is dysmorphic. The ELM is an important structure which causes the formation of the tubulations by touching the base layer first and rolling up the photoreceptors inside them. There are 4 types in which they're flat, where the ELM just separates, J-shape when the tip touches the RP, and then it starts curving back on itself. This is a 3D construction of the ELM that is rolling and scrolling and containing the cells. So the on-fast shows 2 images. There's a pseudo-dendritic pattern when it forms over a fibrovascular scar, and then there's a circular pattern with the like invaginations from the edge when it is at the junction of normal and atrophic retina, as in GA. So when you see ORT, you can know that ORT is has been seen in the presence of previous subretinal fluid, or it is at the junction of intact, that is preserved, and damaged retina. Finally, the choroidal caverns are strange features where you have hyperreflective faces, just hyperreflective faces, and you can see there are overlying areas where there's severe RP chorea capillary damage. So again, a beautiful study now that says that choroidal caverns are not empty and they're likely to contain liquid proteins. The significance is unknown. So thank you for a patient listening, and I think I've just finished on time. Thank you.